So we're back here with Christian, and I just got done, off camera, checking his upper cervical stability. Everything felt fine. He didn't get any of those, red flag signs like lip paresthesia and quadrilateral paresthesia and all that sort of stuff. It wasn't comfortable, but I mean, who is it comfortable on, right? We've all had our upper cervical spines tested, and it doesn't feel great. And so I think it's important to tell the patient prior to doing it, hey, this is going to feel good, but I'm looking for big bad stuff, and we didn't see that with him. So now we're going to get into treatment, and I already kind of tested his neck and locked it out a little bit, and was checking movement and all that, and that felt fine. So I can take him to an end range, and I can do MOBs or manipulations, and I was just sharing with him off camera that the resounding theme of the literature is the value of manipulation. Now, we don't go and manipulate everybody that we see, right? We need to check and make sure it's appropriate for that patient at hand and screen them well and all that kind of thing. But the therapeutic maneuver happens with the speed of the movement, not necessarily the cavitation, although there are some camps out there that argue, no, you got to get the cavitation, you don't have to get the cavitation, yada yada. But I'm starting to believe and think more and more based on the evidence that we're doing neurological stuff here, maybe not as much biomechanical stuff as we once thought. There probably is a bit of a biomechanical component too, but the neurotransmitter release after a manipulation, the reflexive relaxation in the local muscle group after manipulation, those are neuro changes. And so, I don't know, the camp is kind of out for me with regard to that. All I know is what the research says, which is that window of opening, that feel-good window where the patient feels noticeably better after a manipulation, that is only open, so to speak, for 2, maybe 4 hours max, unless we get in there and follow it up with a self-correction exercise, which we already talked about a little bit, but we'll go over that on camera too. We've got to do some sort of corrective exercise to maintain that neurological benefit, or that neurophysiological benefit. And so we're going to start out with an upper thoracic manipulation on Christian, and then I'll take a look at his mid-cervical spine too. Or actually his lower cervical spine, which is a little bit more stiff. His mid was a little bit irritated, so we'll maybe look at his lower cervical spine too, which would actually go with the upper thoracic stiffness too. So we may do an upper thoracic manip, a lower cervical manip, and then follow it up with some corrective exercises that he's going to try. Okay? So, Christian, what I'm going to have you do is, can you kind of cross one arm under the other, hug yourself? Perfect. And what I'm going to do is raise this up. Now, to create a good fulcrum for the technique, what we may want to do is get rid of the pillow, right? Or at least, only have like his upper neck supported, because I want to be able to get my hand under there and create a good fulcrum, a good crisp end feel to do the maneuver. The other thing that's particularly helpful with the upper thoracic spine is having the patient bridge or lift their hips up. That will actually roll them up onto their upper thoracic spine and create a crisper fulcrum for you to be able to do your therapeutic maneuver. So I'm going to start out just doing just rolling him and see how that feels, and then I may actually do the bridge position here. I'm just going to roll you on your side and get my hand kind of under where I want. And one thing that you can do too to get a little bit better lock is you can start in sort of a supinated or a radial deviated position, and then ulnarly deviate and get a bit of a skin lock. That will actually give you a little bit of a better purchase too. So that doesn't feel super crisp to me, so what I may say is roll all the way back over onto your back, okay? Bend both knees up for me, and then just lift your hips up off the table. Good. So that feels like a little bit better, firmer end feel for me. So what we're going to do is I'm going to have you take a nice deep breath, okay, and blow it out. Good. And I'm going to lean on you. Can you feel I'm kind of right on that upper thoracic spine? So do it one more time, and that's going to be a quick pressure into your elbows, okay? So blow it out. Take up the slack. Good. So we got a little cavitation there. So we did the upper thoracic spine. We're going to lay him back down. How'd that feel?
Good.
Feel okay?
Yeah.
So now we're going to turn that. You can undo your arms. So that bridge position is really quite helpful to get a little bit better lock Now what I'm going to do is actually recheck his mid-cervical and lower cervical movement and see if it cleaned up, because there was some research actually by a colleague of mine when he was in PT school where he looked at upper thoracic mobilization and its impact on neck pain. And you know, Josh Cleo and those guys, they talk about this a lot too in their studies. You can manipulate the thoracic spine and get really good benefits with the neck. Now I think that could be related to neurophysiological effects, because the posterior primary rami actually innervates facet capsules above and below its root segment, so you could get a little bit of some analgesic effects above and below. And if you have a mid-cervical problem and you manipulate the upper thoracic spine, you could get some analgesic benefit neurologically. That makes sense to me. The other thing that I think makes more sense with neck pain, because a lot of times it's posturally driven, is by improving thoracic extension, you improve the positioning of the head over the shoulders, over the base of support, and that reduces the threat, so to speak. So they're not going to have as much posturally driven pain. Okay, so I'm going to go ahead and just check mobility again, inflection, because that was the symptomatic thing, and see if it's any better. How'd that feel, Christian?
Fine.
Okay. Let it go the other way. And this side still feels a lot stiffer to me. Like it's just not wanting to side glide left to right. Okay, so we've screened him. I've talked to him about cervical manipulation. I've talked to him about you know, the theory behind manipulation. He's okay with it. So I'm going to take him to an end range position here, and I'm actually going to use a different technique than maybe what some of you might have seen. There's a lot of different ways to manipulate the spine, whether it's the low back, the thoracic spine, or the neck. We know that, and we feel, I think, as a profession, that end range techniques are something that we want to avoid, right? Because of the effects of the vertebral artery. If we turn our head fully one way into primary rotation, the opposite vertebral artery lumen will narrow. You can take a piece of TheraBand or TheraTube and do that, pull on it, and you'll see it narrow. That's kind of what happens with our vertebral artery as we turn our head. So doing just rotation and side bending as a lockout maneuver might not be enough, and might still be a little threatening to him as the patient, and a little bit unsettling for me as a provider. So there's another safer technique that Lori Hartman, the osteopath, and some of his colleagues, I'm sure, have kind of developed, and it's called component technique. And it goes back to Freyd's laws, where you take up motion in one plane, you're going to have reduced motion in another plane. And component technique essentially just is taking up motion or mobility in multiple planes. You're essentially fabricating your own barrier in mid-range so that you're nowhere near end range. So there's very little risk. There's not no risk, there's very little risk, much less than an end range technique. And it's often very comfortable, and you only need a quick little slow arc of movement to get a really therapeutic benefit. Okay, so it just makes logical sense. So how we're going to do this, because he doesn't like to side glide left to right, that's going to be my primary movement that I'm going to do when I do the thrust, and it'll be toward his opposite hip. And so to get him to an end range position, I'm going to flex a little bit, I'm going to rotate, I'm going to side bend, and then you can compress, or you can do traction. You can take up those movements too. So you can side bend a little bit, you can side shear a little bit. You always want to test the firmness of your primary lever. Okay, now that feels kind of crisp to me. Does that feel okay to you to be in that position?
Yeah. Mm-hmm.
Okay. So I'm going to do actually a little mini thrust. I'm not going to do like a full-fledged one, because I kind of want to test the reactivity there. And I would advise that if you're looking at manipulating the cervical spine and the patient maybe is a little unsettled, or it's first or second visit, test it a little bit, okay? And see how they respond. So again, we're going to flex, we're going to rotate, we're going to side bend. I'm going to get him securely against my chest so he feels comfortable. I'm going to side shear. So that's the kind of movement I'm going to do. Does that feel okay? Mm-hmm. Okay, so nice deep breath. And blow it out. Good. How'd that feel? So what I tend to do with that after I do that maneuver is I'll do a little bit of light traction. Traction typically is very non-threatening and comfortable. Okay, so I follow up my maneuver with something that's comfortable and, you know, artsy-fartsy, if you will, to relax them more. And then I'll recheck the movement restriction or the movement dysfunction and see if it improved. You doing okay? So I'll do another little short bout of traction. Then I'll like rotate his neck each way just to comfortable end range, just to stretch. Then I'll recheck the movement again. Okay, so let off. Now I'm just going to kind of hold your head in my hands and we're going to rotate. Let's rotate together comfortably as far as you can go. You good there?
Mm-hmm.
I'll hold him there, just stretch a little bit. And I'll go the other way. He's rotating symmetrically, so rotation looks good. Okay, I'll keep him flexed up a little bit, and I'll check the side glide again. So relax your head and neck for me. And it still is a bit stiff and irritated. So now, you know, we're not going to continue to manipulate him over and over again, right? We did a couple therapeutic maneuvers. Now we're going to teach him some self-management strategies and see how it goes. Okay? So that'll be the next video.